Thanks. Thanks for the organizers for selecting our abstract, and thanks for all of you for making that after lunch. I'll try to keep you from not snoring too loud, so I hope it's not too boring. So I should first say this is an observational study session, but I'm sneaking some data on a very recent placebo-controlled trial, prolific Swedish trial that I was just too excited about to share the data with you. So disclosures, and then long COVID. We've talked a lot about biomarkers yesterday. So of course we do need diagnostic biomarkers. I need just only if it were just to relieve the stigma of patients not having a diagnosis. We won't go into that. Today I'll talk a bit more about biomarkers that might help us guide treatment, whether that is antiviral, anti-inflammatory, anticoagulant, antiplatelet, etc. And then, of course, there's this third flavor of biomarkers, the predictive ones, that can help us, like, predict clinical evolution. It's like the imaging, the wearables, the prompt, etc. So focusing on the biomarkers to guide treatment, I think we all agree that should be preferably non-invasive and, if possible, for healthcare systems, affordable. So this is the only published data I'll show today. The rest of it will be unpublished. I just want to focus on this one because Tim shared encounter data yesterday. Just want to go a bit on the technical nitty-gritty here. So these were, oops, I guess this pointer somehow works on one screen. So what can you hear? So the green are the controls. Matched controls to 48 patients. You see it is this line here detects actually the cutoff of 10 counts, which is in fact one standard deviation above our controls. This is done on a max equipment. However, if you do the same on a sprint equipment, you need 3 standard deviations, which goes then up here. And that means that, like, instead of 60% positives, we'd have like 20 to 30% positives for viral persistence, which is in fact really close to what we see with the spike Simoa antigenemia assay. So I think we're not discordant in our results. I mean, it depends on the technological details on how much, in fact, we can detect of this viral persistence. So the matched controls actually did have very low levels, but some detected in some of them of the antisense RNA. However, if you use the total viral load as a cutoff, you can see we roughly saw again 60% of patients being positive for viral persistence. Very happy to say this is roughly similar to what Dominique Salmon and Morgan Bomzel in Paris found in their platelet assays. So stay tuned for the platelet link here. About patient-reported outcome, this is the COPE chart that our clinician is using mostly. So this is data we've shown before. So if you look at the red dots, these are the COPE chart scores, and patients with higher scores are having worse, as you can see here, having worse scores of depression and anxiety. So as you can see here, this patient with worse anxiety and depression have like 50% of them are above this threshold, have like detectable antisense RNA. And on the other hand, the same patients with high anxiety depression scores had lower immunometabolism. Again, that does ring a bell with some of the data presented before in the biomarker session. So we've updated this a bit. We have now more patients, and we were able to confirm this significant association with anxiety and depression. So again, sorry, I'm only pointing here at one screen. So again, we see the significant increase in anxiety and depression and now in a larger number of patients. So that was for the antisense RNA, which, as you know, is like a very good, or I think we believe, marker of viral replication. Then surprised to us when we increased the number of patients that we also saw a significant association with the Mpro Protease, which is in fact the target of Paxlovid, as you know. So in these patients, we saw, in fact, all of the positive ones. And again, I'm trying to point here. So you see in the group, those with high fitness scores, with higher fitness levels, mean they have lower scores. Only one of these patients tested positive for the Mpro RNA, whereas half of the patients with the very low fitness scores or worse scores were having detectable Mpro RNA. So we do believe this might be a biomarker for patient-reported fitness. And since we talk about viral persistence, it's always important to have orthogonal assays. So we were lucky to be able to compare it with the Simoa. So we compared the transcriptomics with the Simoa assay. And in these 37 patients that paired results, we saw that, in fact, the patient that was spike positive, 7 out of 30, so it's roughly what was seen in other cohorts. All of these patients were having higher levels of the Mpro RNA, again, so the protease target of Paxlovid, and in association also of type 1 interferon, that's strikingly higher levels. So we do think there might be some, at least, concordance between the different tests. So this is just a busy slide showing lots of correlations. So in fact, can be short here, this Mpro RNA is correlated to all of the other viral RNAs except spike, also correlated to the antisense RNA, so it might be also a marker of viral persistence. And this is confirmed also by a positive correlation with both the receptor ACE2 and the co-receptor, TMPRSS2. And then again, talking about the platelet link, these 3 platelet-expressed genes were highly correlated to the Mpro RNA. So, yeah, just summarizing. Then, next step, we tried to purify platelets from long COVID patients. So in these 5 patients, we had paired samples of purified platelets with leukocyte depletion, and then compared it to whole blood. So this is what you see in this volcano plot. So actually, whoops. Yeah. So first of all, this purification worked, because we see here in this circle all of these validated bona fide platelet genes, such as integrin beta-1, CCL5, which, as you know, is important because it's the agonist that is actually targeted by Maraviroc, P-selectin, another biomarker shown by several people. So our purification worked. And then in red here, you can see that, in fact, most but not all of the SARS-CoV-2 viral RNAs, so ORF3, ORF8, and the membrane protein, and the antisense as well, were highly enriched in platelets. The same was true for the associated receptor, so ACE2, also interferon alpha again, but however, as you can see here below, it's maybe a bit hard to see, in the circle, trying to point here, okay, won't make it, somewhere there below, you can see that Mpro and Van Spike are not platelet enriched because, in fact, they're mixed between the 2 reservoirs. So I think this might be due to phagocytosis, maybe by monocytes. Okay, so talking about observation studies, this was a call that most of the patients and the clinician we're working with made some time ago. So grassroots clinical trials, we're not there yet, but so what we like to do is speed up clinical trials and making them patient-led and patient-designed. So this was one of the great designs that these 2 patient experts came up with, Elena and Tommaso. So we had a personalized list of long COVID symptoms that were chosen on a Google Sheet in a drop-down, and they were quantified on a visual scale. This was, in fact, an online cloud-based platform which gave us real-time info, also allowed us to identify any adverse events that might occur. So the primary outcome of this study was an average drop in these personalized symptoms over 15 days of treatment, and a secondary outcomes, we had this scoop chart that showed also measures in the ongoing follow-up and also the biomarker changes. This is one example of a non-responder on the top. As you can see here, the patients have listed their symptoms from fatigue, post-acute malaise, insomnia. You get a total score on day 1. As you can see, this patient did not respond. You can see the numbers stay in the red over the course of the treatment. The lowest patient is a responder. As you can see here, they start higher, but things are looking on the greener side, so there's a significant drop in these personalized symptom scores over time. And when we analyzed all patients together, we saw an average 30% drop in these symptom scores, which was significant at 15 days. So secondary outcomes, these scoop charts again, so we're measuring 6 dimensions, and just showing here, these are the patients treated with antivirals. You can see strong variability, but a significant drop. On the other hand, we did not have a placebo. We had like the first-line treatment with antiplatelets, and we saw there was no significant change in these 49 patients over time. So, as I said, a very short update. Peter Broden showed this data on the Keystone Conference, so I'm not going to the clinical design, but in these patients, there were roughly two-thirds on, two-thirds were on placebo, one-third on Paxlovid, and 1/3 on the placebo. There were 14 different clinical measures. Overall, that's important. And unfortunately, this trial also failed this primary clinical endpoint. However, in the post-hoc analysis, we saw that if we measure again this Mpro RNA, so the target really of Paxlovid, we saw a significant decrease across patients when we compare the placebo to the Paxlovid. So we saw roughly a 20 to 30% decrease in the proviral protease, and this was significant at 45 days after treatment. And in the other graphs, you can see a difference between Paxlovid and placebo for all of the other viral RNAs, which was significant at all time points, either at 15 or at 45 days after treatment. So then what about the clinical score? So inspired by what we saw in our Belgian open-label study, we tried to calculate the composite score. And then, in fact, here, in fact, this composite score is summarizing all of the 14 biological and clinical measurements, which included reactive hyperemia index, which included steps per day, measured using wearables, the poll questionnaires, etc. So just summarizing all of them, you can see here that when we put a cutoff at 75% of clinical response, you can see there were like 35 responders in the Paxlovid group, even some super responders here, as you see here, 4 or 5 patients responded like in every single clinical outcome measured, whereas these were significantly lower in the placebo group. So, significant drop in the composite clinical score, and then Peter's group also looked at machine learning to look at the encounter data, as I said, that we had, and he found several significant predictors of responders versus non-responders. First of them is IGF-2, so again linking to insulin metabolism, and also some of them were in fact, interestingly, platelet-specific genes. So when we overlaid the number of genes correlated to clinical score, we found that 16 of them were actually overlapping with the genes that we defined as being platelet-specific in our patients. Again, including CCL5, but also HDAC5, IL-12, interferon alpha again. And then, as you can see here on the graph, we were able to validate these in the Belgian small open-label study. So IL-12 is in fact a negative predictor of Paxlovid response.
We're over time, so
okay, sorry.
Yeah.
Okay, want to summarize. So this is the machine learning, going to conclusions. So Mpro RNA was higher in patients with low fitness scores and also in spike positives. Purified platelets carry higher levels of SARS-CoV-2 RNA, so confirming their role as a reservoir. Personalized symptom score, I think, is the way to go if you want to have like better clinical outcomes. Didn't show here, didn't have the time, but there was also a drop in neurodamage markers at 15 days after Paxlovid. And then in the placebo-controlled trial, we saw a significantly lower Mpro RNA, so the target of Paxlovid, and a significantly higher composite clinical score in Paxlovid versus placebo. Of course, we should say these are post-hoc analysis. Platelet-expressed genes, IL-12A, which I showed, HDAC5, which I didn't show, were validated as predictive biomarkers in both the open-label and the placebo-controlled trial. So we do believe these are mechanistic and druggable links that match viral persistence, platelet coagulation effects, and neurodamage, which are major players, maybe root causes in long COVID. And again, underscoring the potential biomarker-guided precision medicine in long COVID. And then quickly acknowledging all of the co-workers. Thank you for your attention.
Thank you very much.